Hi everyone, welcome to the Top 5 Things Feeds Should Know About series. I am Cristian Toribio Dionisio, Vice Chair of the Quadra Feed Committee. In this session of our series, we will cover the top 5 things feeds should know about hereditary alpha tryptasemia. Our guest presenter is Dr. Jonathan Lyons. Dr. Lyons is a professor of medicine within the Division of Allergy Immunology at University of California, San Diego. Using immunogenetic approaches, the Lyons Lab seeks to identify mechanisms critical to allergic inflammation and hypersensitivity that can be targeted to conduct first-in-human clinical trials. Dr. Lyons has participated in the discovery and characterization of several primary atopic disorders, inborn errors of immunity presenting with severe allergic inflammation, including PGM3 deficiency, ERBIN deficiency, CARD11 haploinsufficiency, and STAT6 gain of function. And his work describing and characterizing hereditary alpha tryptasemia has fundamentally changed the workup and diagnosis of mast cell disorders. Dr. Lyons has received several awards for his work. Welcome, Dr. Lyons, and thanks for leading this session. I will turn it over to you to get us started on your top 5 items.
Thanks, Christian. This is a fantastic forum. I really appreciate the invitation, and hopefully this will be beneficial to folks because you will see in your careers plenty of patients with hereditary alpha tryptasemia, something that often in patients will refer to as HAT or HATs, and certainly inborn errors over the course of your careers as these as sort of next gen sequencing has become more and more common. Five things. I thought about five words to try to kind of nail this down. So we're going to talk about common, monogenic, structural, modifier, and absence. And so I'll go through those five, and then Christian may have some questions sort of at the end. You guys can always reach out to me directly, personally, if you have specific questions about patients and things, and I'm always happy to interact. So common. Hereditary alpha tryptasemia is common. It affects about 6% of folks in the United States, and in at least Western countries in UK and the EU where this has been studied. It appears to predominantly affect white people for reasons we don't fully understand yet. But if you see a patient in clinic who has a tryptase above 8 and certainly above 11.4, the likelihood that they have hereditary alpha tryptasemia, unless they're in renal failure, is quite high. It's estimated that probably 9 out of 10 of those folks who have a high tryptase that you're going to see in clinic have HAT. And so performing tryptase genotyping is what is really sort of the technical term for it, but you'll hear people call it HAT testing or tryptase CNV testing. This is a droplet digital PCR assay that's run at a couple of different laboratories, commercial laboratories now. My laboratory developed the assay many years ago now, but this testing is indicated and for reasons that we'll talk on point five. The second thing that I think you should know about hereditary alpha tryptasemia is that this is a monogenic trait. So when we talk about genetic traits, there are a number of them. These include people having genetic determinants, single genes, or monogenic, that cause certain characteristics, some of which are problematic, some are not. So wet or dry earwax, lactase persistence, so people who develop full-blown lactose sensitivity, cleft chin, freckles, widow's peak, things like that. Even some cases of color blindness are all monogenic traits in patients or in individuals, really, because none of those are really genetic disorders, right? But some genetic disorders are considered monogenic traits in part because of the frequency or sort of the prevalence in the population. So these include things like cystic fibrosis, sickle cell disease, thalassemia, certain familial cholesterol disorders. So there are monogenic traits that can cause disease or contribute to disease. Really, we think of HAT as a monogenic trait that's a major modifier of mast cell disorders and reactions. And I'll get to that when we talk about modifier in point four. So the third point I would make is that this is a structural change in the genetics. So often when we think about genetic disorders or genetic traits, when we talk about Mendelian inheritance, we think about pathogenic variants in that they're like usually a missense, like a single amino acid change resulting usually from one base pair change. In the case of hereditary alpha tryptosemia, this is not a mutation, and this is not a change in protein. What this is a copy number problem. And so, what we have in the case of hereditary alpha tryptosemia is that one of the two primary genes, so there's two genes that encode tryptases that are secreted and that are, we believe, are sort of the two that are important physiologically, and that's TPSB2 or tryptase beta 2 or TPSAB1 or tryptase alpha beta 1. So those are the two genes. They sit right next to each other on the short arm of chromosome 16, and they both encode tryptases, where beta 2 is only known to encode beta tryptases. AB1 can encode either alpha or beta, and that's why the term AB1. And that's a little bit confusing because in the general population, we have structural, or excuse me, copy number variation, where about 30% of folks have no alpha tryptase. Somewhere between 40 to 50% have one copy, and somewhere around 20 or so percent have two copies. And these are coded at these two loci, and they're inherited as a haplotype. So basically, because the genes are tightly linked near to each other, and because of the structure of the surrounding DNA, they don't independently assort, meaning that you don't actually get different copies from mom and dad. You get a haplotype from mom or a haplotype from dad. In the case of hereditary alpha tryptosemia, what we have is extra copies of alpha tryptase, the normal wild type alpha tryptase, at TPSAB1. So instead of just getting one copy from at one locus and one copy from another locus as a haplotype from a parent, you're getting two or more at TPSAB1 that are both alpha, and then beta at TPSB2, and that defines hap. This kind of structural variation was actually quite hard to see for a while, partly because of the similarity between the beta 2 and the alpha beta 1 locus. And so it took us a long time to sort out and actually figure out what was happening at the tryptase locus. We now know that there are individuals with up to 10 extra copies, and probably those with even higher order copy number. And with each extra copy of tryptase, alpha tryptase, at TPSAB1, it increases tryptase levels by approximately 9 nanograms per mil. So in the general population, a normal tryptase is 4. If you have had, if it was just a copy number problem, if you started with 4 tryptases and your tryptase is 4, if you go up to 5 now, with that one extra copy of alpha at TPSAB1, your tryptase should really go up to 5, but instead it goes up to 14 on average. And that's because that extra copy is overexpressed. And it's that idea of overexpression that we'll talk about in point 4 that's really sort of a driving factor here, and helps us understand and explain some of what we're seeing in hereditary alpha tryptosemia. So we have common, we have monogenic, we have structural. Now we have modifier. So when we think about Mendelian genetics, often we're tempted to think about syndromes, and we're tempted to think about causation. So we have gene X. When it gets screwed up or it gets changed in some way, or in this case, overexpressed, it causes problem X. And so that's great when we're talking about pathogenic variants causing specific diseases. It's less useful when we're talking about genetic modifiers, particularly in the context of allergic disease. Infectious disease is actually somewhat similar if you think about it, because in both cases, if you have a genetic change, but you never encounter the environmental problem, that being the allergenic exposure, like the insect sting, or in the case of certain certain inborn errors, maybe that's herpes virus or it's EBV, depending on the kinds of either toll-like receptor or other changes that you have with relation to resulting in things like HLH, then you don't have a problem in many of these cases. So to take that a step further, when we talk about hereditary alpha tryptosemia, not only do we not know whether just having this genetic trait causes a problem, we firmly understand at this point that if you have an allergic problem, this is a common modifier of the severity of that disease. And I think the best example of this is stinging insect allergy. And the second being mastocytosis, and I'll touch on those two really briefly. So, in the context of stinging insect allergy, so we're talking about Hymenoptera envenomation. So these are stripy flying things, right? Like this is wasps, hornets, yellow jackets, honeybees, etc. So if you have hereditary alpha tryptosemia, you are no more likely to develop a stinging insect allergy than if you don't. So the frequency or the prevalence that we've observed in multiple studies of HAT among individuals with stinging insect allergy is not different than the general population. But if you look a little bit more granularly, if you look a little bit more carefully, what you see is that if you have both hereditary alpha tryptosemia and you're unlucky enough to develop a stinging insect allergy, you're about twice as likely to have a bad anaphylactic reaction than if you didn't have HAT. And in fact, what you see is a whole shift where we effectively see no individuals with HAT in the studies that have looked at this with large local reactions, very few with grade 1, 2, or in some cases 3, depending on which system you're using, whether it's Mueller versus others. And then most of the patients, or at least twice as many of the patients, having grade 4 or more severe reactions. If you add on clonal mast cell disease, what you see is that almost 90% of those patients, depending on the study you're looking at, it might be more than 90%, have grade 4 reactions. So if you have HAT and you have SM, systemic mastocytosis, if you are to develop a stinging insect allergy, you're kind of in a bad situation where you're very likely to have a bad reaction. And so we see this additive effect among patients with mastocytosis. In the latter, in mastocytosis, this effect is not unique or specific to venom allergy. And in fact, the more we look, it seems that this is not a specific phenomenon even to venom or mast cells. This seems to be generalizable to other mast cell mediated reactions. But among those with systemic mastocytosis, we see about a threefold increase in HAT relative to the general population, such that about 15 to 18% of systemic mastocytosis patients have hereditary alpha tryptosemia. We don't know why. There's some discussion in the literature, there's discussion among experts as to why this association exists. We believe that it's likely that it's because individuals who have HAT and have SM have more symptoms. They're more symptomatic. And this has been shown using some validated symptom scoring. And certainly in all 6 studies comprising over almost 2,000 patients with SM or other clonal mast cell disorders, what we've seen is that they're more likely to have systemic anaphylaxis, about, again, twice as likely. So when we think about HAT, this is an overexpression model, a natural overexpression model that sort of enhances or augments or modifies the severity of mast cell mediated reactions. Importantly, as I mentioned with the genetics, we have the human knockout of alpha tryptase, and then now we have the natural overexpression model in HAT. And really what that is sort of the two tools you would use in the laboratory if you wanted to study a disorder or a gene, right? You would knock it out or you would overexpress it to see what sort of function it has or what impact it has on physiology. So we're still learning, based on these naturally occurring knockout and overexpression models, what the sort of impact is of alpha tryptase on human physiology. And so there's a lot of work left to be done, but certainly there is evidence that this impacts the severity of food allergic reactions, reactions to medicines, and certainly there's a lot of data supporting the role of tryptases in asthma and other disorders and healing, wound healing, et cetera. And so understanding how this might modify those conditions, I think is really a big, important thing to do that we're working on. Okay, point 5. So we've done common monogenic structural modifier, absence. So one of the most important things to recognize clinically is that we get referred a lot of patients with high tryptases, right? Like that's a common referral, funny symptoms or, anaphylaxis, somewhere on that spectrum. And they have a high tryptase and they get sent to allergy for evaluation of mast cell. I don't like the term mast cell. We all have lots of them, not just one. But mast cell activation syndrome, for instance, they're being referred for evaluation thereof. The finding of having a tryptase that's elevated in the absence of hereditary alpha tryptosemia is a highly specific finding that's associated with the identification of patients with clonal mast cell disorders. So it's not entirely agreed upon what the cutoff should be. Our data from about 700 patients that we modeled this on would indicate that 11.4, that kind of number that's already on the sheet, for reasons that are entirely distinct from why we came up with this number, is a really good cutoff for individuals who don't have HAT. So in the absence of hereditary alpha tryptasemia, a cutoff of tryptase, or an upper limit of normal of 11.4, is a very good inflection point where if you have a tryptase above 11.4 and you don't have HAT, the likelihood that you have a clonal mast cell disorder is extremely high. The specificity of that finding in certain studies has been upwards of 97, 98%. The sensitivity is low, right? Because there's plenty of patients walking around with clonal mast cell disorders who don't have a high tryptase. Similarly, there are new cutoffs needed when you have HAT, because obviously you're going from a baseline of 4 to a median baseline of 14. And so it turns out we've modeled this, and there is a website online called BST Calculator, that you can identify what the baseline serum tryptase level should be. There's another one called Tryptase Calculator, spelled with an I, that can help identify sort of what's sort of a meaningful rise in tryptase. But it turns out the two that you should really remember is the 11.4, and if you have HAT, I think 90+% of patients with HAT have one extra copy. The upper limit of normal is approximately 40 for those folks. And there's a couple ways to get there. We modeled it, and you can also use another sort of back of the napkin math where you divide the tryptase level by the number of extra copies plus one. In that setting, you have to assume that the normal upper limit would be 20. And so by doing so, you get to 40 as well as the upper limit, because 40 divided by 2 is 20. So that's the 5 things that I think are most important currently. So this is a common monogenic trait caused by structural variation. It's a modifier of severe allergic disease, and when tryptases are high in the absence of HAT, we need to be highly suspicious for clonal mast cell disease. Christian, did you have any questions for me about all of that?
Oh, yes. Thank you, Dr. Lyons. Yes, I think that there are a few questions or a few points that maybe you can clarify to us, especially, like this series is focused also for first-year fellows, and probably some of them have never heard about HAT, or not even like knowing like how to manage or diagnose this disorder. Um, First of all, and I think that in the past, in other lectures and in other meetings that you had, some people also asked you about these cutoff numbers, right? You mentioned tryptase greater than 11.4. In the absence of HAT variants, is very likely that these patients has mastocytosis. But you also mentioned that there is a number, another like magic number, number 8, and then we have this question, right? So what happened in those who have between 8 and 11.4 and they don't have evidence of HAT, but they have like the tryptase is elevated? Or in other words, like, should those group of patients be also evaluated for HAT, or how would you manage these patients with tryptase greater than 8 but less than 11.4?
Yeah, then this comes up in the literature and amongst experts as well. Thanks for raising this question, Christian. So between 8 and 11.4, we're in a gray area. When you think about distributions of populations, you just sort of envision this bell curve, right? So if you envision a population sort of distribution around 4, centering around 4, and you envision sort of the next distribution centering around 14, you end up with this sort of overlap of the kind of bell curves between 8 and 11.4. And so individuals with a tryptase above 8 certainly deserve to be screened for hereditary alpha tryptasemia, because it will help explain the clinical picture. The frequency of having a tryptase above 8 is actually quite uncommon, and it's more common among allergic patients, it seems. But just having that in and of itself it's worthwhile to screen for HAT. Between 8 and 11.4, well, first, let me back up for a second. Diagnosis of clonal mast cell disorder is really clinical diagnosis, right? And you do not need to have a high tryptase. So really, any adult with syncopal anaphylaxis, and actually most children as well, at least deserve consideration of a workup. I would argue in adults, especially if this is a new onset reaction, for instance, even to foods or stinging insects, and you syncopize from anaphylaxis, you deserve a thorough workup for clonal mast cell disease, regardless of your tryptase level. If you have other symptoms that are less well defined, they can be any of the range of symptoms that have been reported in association with either MCAS or um, mastocytosis. Then you have to kind of use your clinical gestalt and acumen in that between 8 and 11.4 as well. So having a tryptase between 8 and 11.4 isn't sort of a like a let's go when you need evaluation for clonal disease. So yes for HAT, no for clonal disease in that gray zone. Certainly trending it over time is something that we often do. And sometimes what we'll see is that people will sort of declare themselves. I should also point out that it's not common, but there are a few other disorders, well, at least one other disorder we're aware of, where elevated tryptases are seen for reasons we can't fully explain yet, and that's eosinophilic GI diseases. So there is that sort of narrow sliver of the pie outside of clonal disease and HAT.
Okay, thank you for the clarification. And then I was thinking about you mentioned about the thinking on HAD as a more like a genetic modifier disorder rather than a disease itself. And as you mentioned, the patients may not even notice, or we may not even identify the patients with HAD until they're exposed to a particular triggers. You mentioned about the sting insect allergy. You also mentioned about mastocytosis. You briefly mentioned about like possible other allergic disorders, but I would like to ask more like about data in other kind of allergic disorders because in an allergy clinic we face patients with chronic urticaria. We face patients with very hard to treat, sometimes allergic rhinitis or asthma, or even like in the setting of food allergy or other food challenges. Some patients like fail, or even though they've been like like the titers are kind of like, IG titers are kind of lowering and the skin test is lowering, but they still have some reactions. Would you say that those patients may also have like an underlying HAT? Would you like maybe consider testing in those patients, even though the tryptase levels are not necessarily high, or how would you manage, or what would you do in these scenarios?
Yeah. So, in general, well, not just in general, if patients do not have a tryptase above 8, the likelihood they have had is next to 0. And so, really, having a elevated tryptase at baseline is really the primary and really the only indication to do genetic testing for HAT. Rarely in the literature, individuals have been reported with tryptases as low as 6.5 and associated with HAT. My suspicion, at least based on our data, is that if you recheck the tryptase, they have HAT, and if it remains low, more than likely either they don't have HAT and they have some other structural variation that looks like HAT in the genetics testing, or something else is going on. But in general, like in Mendelian studies, we've never seen a tryptase below 8. Um, Now, we need to do more work when it comes to these other disorders and to know how to counsel patients with regard to management decisions that might change. As of now, there are no consensus recommendations about how or when we would change management based on HAT. In the mastocytosis community, there are some physicians who are more aggressively sort of screening for HAT among sort of everybody, even if they don't have because of mastocytosis, obviously you can have a high tryptase because of mastocytosis, but we know many of them have HAT. So they're still only screening people with a tryptase above 8, but they're screening everybody with a tryptase above 8, even if, they thought they already had the reason that there was a tryptase that was high. In that context, or in those contexts, I should say, there is this idea that there is a change in anticipatory guidance. Some of those patients seem to have harder time with immunotherapy and things like that. We don't have hard data on or at least replicated data on the impact in these contexts yet. Abigail Lang at Lurie Children's had a nice study that we participated on, showing that among peanut allergic kids, for instance, really it was the presence or absence of alpha tryptase. It wasn't HAT. So HAT wasn't super common in her cohort of peanut allergic kids who were challenged. But what we saw is that among those who were challenged, so these are all patients, peanut allergic kids who were challenged and reacted.
Mhm.
Those without alpha had the lowest reactions, and those with any alpha were all higher. We saw that with increasing amounts of alpha, there was sort of this gene dosage impact, but potentially in the future, at least in moderate to higher risk patients, tryptase genotyping, even when tryptases are normal, might give us sort of risk stratification for some patients, particularly if they have comorbidities like asthma, where we might put them at higher risk of having a bad outcome if they were to have an allergic reaction to a food challenge. So, you can envision where we're not doing this to test for HAT. We're actually doing this to risk stratify based on the number or presence or absence, really, of alpha tryptase in general. And so, going forward, that might be something people are doing in the future, particularly now that genetic testing of tryptases is widely available. And so, to answer your question, that's a long answer to a relatively short question. We don't have new and specific guidance based on the presence of HAT. I mean, we've only known about this for about 10 years now, so we're still learning. But we do see hints that there may be one like risk stratification for certain situations just based on tryptase genotype and not even specifically HAT, just whether you have alpha tryptase or not. And then potentially when we talk about certain scenarios where you're, especially among those with clonal disease, where you're more likely to have, again, a bad outcome to either an exposure or a venom immunotherapy, for instance, where, you might be more inclined to even reach for omalizumab or something like that prior to starting immunotherapy in the anticipation of having difficulty based on sort of reaction, sting history, et cetera.
Okay. Okay, thank you, Dr. Lyons. I think that those were my more important questions, and I think that you already highlighted also in which clinical settings we should consider in HAT evaluation. As you mentioned, use um, we cannot just go and test HAT just with the absence or any kind of symptoms that suggest that there is like this disorder, especially when it's insect allergy, as you mentioned, and also with mastocytosis. Um, I don't have any other extra additional questions. Maybe you would like to add one extra point or a few other, or just one extra thing.
Yeah, I guess the one extra thing I would add is that remember that this is common. And so, um, I've had a few conversations, particularly with folks recently, about the concept of there's a tendency or a desire, right, to come with a unifying diagnosis and an answer to sort of a constellation of symptoms. And I think we need to be very careful about misattribution of symptoms to HAT. Certainly, when we first described it, there were a lot of associations that we found that we have since invalidated. That's the whole point of science, right? Is that we don't seek to sort of codify our results. We seek to challenge them and test them. And so a couple of the associations that were initially described that don't seem to bear weight any longer include joint hypermobility, so connective tissue hypermobility, hypermobile EDS, that kind of spectrum of disorders, and autonomic dysfunction, at least POTS. And so in the initial cohorts that we recruited at the NIH Clinical Center, individuals had a lot of those problems because connective tissue problems run hand in hand with genetic causes for allergic disease. When we're talking about Job syndrome caused by dominant negative STAT3 mutations, when we're talking about Loeys-Dietz syndrome with TGF beta pathway mutations, these patients have severe connective tissue abnormalities and a lot of bad allergic disease. And it's not unique to just those. There are plenty of others. Even filaggrin's technically sort of a connective tissue problem, right? Like that's a problem with skin barrier function intrinsically. So those when we recruited patients in the first place, many of those patients had those comorbidities and had HAT. And we subsequently went to work with collaborators, both nationally and internationally, to seek cohorts that were well defined who had connective tissue abnormalities and were recruited on the basis of that only. Or when we worked with colleagues down here to look at patients who were recruited and had well-defined POTS. Indeed, what we found is that there was no association between HAT and either of those or that those groups of conditions. And so it's important, I think, when we look at our patients to not say you have HAT, so that explains all of the 30 problems on your problem list. Unless a mast cell is clearly involved and tryptases are clearly sort of implicated in the either the pathobiology or the physiology of what you're talking about, you need to be very careful about misattribution because I think that doesn't help our patients. Um, and it can be problematic. So I think that would be kind of the one other thing I would bring up.
Okay. Okay, before signing off, I would like to thank again Dr. Lyons for volunteering his time. We appreciate the information and guidance you shared with us today. And if you have any follow-up questions after viewing this session, you can reach out our staff, Fit Staff Liaison, Marie Duran at mduran@quadri.org. See you soon.
Thanks, Christian.